Hello, my name is Dr. Ukiri Richard, still giving you this podcast on basic cardiology. Today we are going to talk about intermittent rapid heartbeats. A 64-year-old patient has been experiencing irregular heartbeats. Was told by his house doctor some time ago that he has a heart rhythm disturbance, but lately all has been well. He also experiences thoracic pressure on severe exertion. He is a non-hypertensive patient and has been taking 5 mg Ramipuli for 2 years. He smoked until 5 years ago, 40 packet years. On examination, the blood pressure was 150/90. The pulse was 64 per minute, rhythmic. Heart and lung auscultations were okay, and all the general body examination findings were normal. What examination or what test would you request for? Well, I will request for a resting ECG, an echocardiography, a stress ECG, an ECG Holter monitoring, 24-hour blood pressure Holter monitoring, and routine laboratory tests. The ECG showed a sinus rhythm, left axis without repolarization disturbances. There was borderline Sokolov index for left ventricular hypertrophy, SEV1 and arrow in V5 was 3.5 millivolts. In the echocardiography, there was a normal left ventricular systolic function without contractility disturbances. There was also a grade 1 diastolic dysfunction from mild left ventricular hypertrophy. The left atrium was a bit dilated, 43 millimeter. Aortic, mitral, and tricuspid valves were normal. In the laboratory test results, apart from raised LDL of 155 mg/cent and reduced HDL of 37 mg/cent, the routine laboratory examination findings were also normal. Then the stress test went up to 150 watts, which was 84% of the submaximal heart rate. The test was discontinued due to muscular exhaustion. At maximum stress level, the patient had light thorax symptoms and significant ST depression, 0.2 millivolt in lead V4 to V6. The heart rate rise under stress was physiologic, but the blood pressure rise was pathologic, 220 to 120 millimeters of mercury at 100 watts. There were no heart rhythm disturbances. So my question is, how do you interpret these stress test results? Well, I see it as a formal ischemic reaction with discrete clinical symptoms. A differential diagnosis here is a hypertensive heart disease as the background cause. While monitoring the patient, you noticed a rhythm change on the monitor where there was a sinus rhythm, and suddenly one extrasystole followed by sinus beats, and then rapid narrow complex QRS tachycardia of about 120 to 140 per minute with irregular intervals. How do you judge this heart rhythm disturbance? Well, this is what you call paroxysmal atrial fibrillation. The first action is sinus action, followed by ventricular extrasystole, followed by another sinus action, and at the end, the atrial fibrillation. Okay, that was a finding in the ECG Holter. Then the BP Holter showed atrial hypertension, not well controlled, but with sustained night dipping. So my question is, what's your next step? Well, the pathologic stress test is an indication to carry out a cardiac catheterization. Okay, you did the cardiac catheterization and you saw a high-grade LAD stenosis in the middle part. The ROCX and the right coronary artery had severe arteriosclerotic changes. So the LAD is to be managed or handled with a stent. Because it is the dominant vessel, despite a diameter of 3.5 millimeter, due to the length of the stent, which in this case is 23 millimeter, and everolimus medicated stent will be used. The everolimus medicated stent is science. So my question now is, what is your take on thrombocyte aggregation inhibitor and anticoagulation in this patient with atrial fibrillation and medicated stents? Well, in emboli prophylaxis, in cases of non-valvular atrial fibrillation, we use the CHADVAC score to determine who will get and how the duration of the anticoagulation. The CHADVAC score: C, congestive heart failure, hypertension, age above 73, diabetes mellitus, stroke or TR, vascular disease, age between 65 to 74, and the feminine sex. The earlier used CHAD score has been overtaken by the CHADVAC score, which was validated through a large patient count. In the CHADVAC score, the age above 65 to 74 takes one score, while above 75 years takes two score compared to the CHAD score. And here also there are additional points for feminine sex and vascular diseases, which both carry 1 point each. Patients with CHADVAC score of 0 are to be given aspirin 75 to 325 milligrams a day, or may not even require anything. Patients with CHADVAC score of 1 should have aspirin 75 to 325 milligrams per day, or an anticoagulation with INRO 2 to 3. And patients with CHAD score above 2 or above needs to take anticoagulation with INRO 2 to 3.0. So our patient has a clear indication for dual platelet aggregation inhibitor with after drug-eluting stent, and also an oral anticoagulation because of atrial fibrillation. Principally, the solo use of thrombocyte aggregation inhibitor reduces emboli risk in atrial fibrillation by 30%. But in this our patient with a CHADVAC score of 2, this is not enough. So we have an indication for triple therapy, that is double platelet aggregation plus anticoagulation. Don't forget that the triple therapy is associated with high bleeding risk. Presently, the European Heart Organization worked out a consensus document, which is called the Has Bled Score, that can help to tell you the risk of bleeding and the recommended thrombocyte aggregation or anticoagulation. Has Bled stands for hypertension, abnormal renal or liver function, which they all carry 1 point. Renal and liver function carries 1. If both are present, they carry 2 points. Stroke, bleeding, labor ENRO, elderly patient above 65 years, and drug or alcohol abuse, which both carry 1 point each. So in this our patient will give a triple therapy with clopidogrel 75 mg, aspirin 100 mg per day, and an oral anticoagulation with INRO 2 to 2.5. In some cases, this recommendation has been critically discussed because some guidelines recommend just dual platelet aggregation after Limus medicated stent for 6 months. Some authors also recommend the long-term therapy of with oral anticoagulation in combination with one thrombocyte aggregation inhibitor. But this has not been backed by any scientific study, which is why the authors recommend just the oral anticoagulation as a long life therapy. So what would be your recommendation for the rhythm control? Well, in patients like this, our patient now with structural heart disease, he has hypertensive heart disease and coronary heart disease. They have high risk of medicine-induced ventricular proarrhythmia when they use antiarrhythmic agent from class 1C. Sotalol also should be given with care. Amiodarone has very less proarrhythmic effect and therefore can be given in patients with structural heart diseases without fear, and can also be given on outpatient basis. But don't forget that amiodarone has very many side effects, which is why in our day-to-day clinical practice, a cardioselective beta blocker are given. There are clear indications for this in the guidelines. Additionally, cardioselective beta blockers have positive effects on the related comorbidities of the patients. An alternative to amiodarone is dronedarone. This is a new class 3 antiarrhythmic agent that is similar to amiodarone but does not have iodine and has been used since 2010 for treatment of non-permanent atrial fibrillation. Okay, since you are talking about side effects of amiodarone, could you tell me some of them? Well, photosensitivity, polyneuropathy, gastrointestinal complaints, bradycardia, torsade point, which is seldom, pulmonary and hepatic toxicity, thyroid dysfunction, hyper and hypothyroidism, ophthalmic side effects, interaction with medicines that are metabolized over the cytochrome P450-3A4 like simvastatin, cytochrome P450-2D6, and cytochrome P450-2C9. Under treatment with ACE inhibitor and angiotensin receptor antagonist, it has been noted that there is reduction in the recurrence of atrial fibrillation. Okay, our patient was additionally given 5 mg bisoprolol. Under this treatment, they never felt the palpitations again. A 24-hour blood pressure measurement done thereafter showed controlled blood pressure, and because of his coronary heart disease, he was given a lipid reducing agent, simvastatin. For the thromboembolic prophylaxis, he was given fenprocomon, which is warfarin. For the first 6 months after the drug-eluting stent, he got a dual platelet inhibitor, platelet aggregator inhibitor with clopidogrel sulfate and aspirin, 100 mg aspirin, 75 mg clopidogrel sulfate. And during this time, the INRO was recommended to be 2 to 2.5. After 6 months, the clopidogrel was discontinued and the patient was placed on a long-term therapy of aspirin and fenprocomon. For the coronary heart disease, the statin therapy was given to reduce the LDL level to below 100 per DL, up, or if possible, 70 per DL. Thank you very much.